Welcome my dear to this your channel, Clinical Consultant. This video in English. This time we will talk about sickle cell anemia and I hope it can help you. If it helped, just leave your subscription and your like. Let's move on with the presentation. Definition. Sickle cell anemia is a hemoglobinopathy characterized by the production of hemoglobin S, the result of the substitution of the amino acid value for glutamic acid in the 6th position of the gamma globulin chain. When exposed to a lower pressure of oxygen, the red cells assume the shape of sickle, which causes their stasis at the level of the capillaries. Pain crises are caused by ischemic tissue injury due to obstruction of blood flow by sickle red cells. Epidemiology and demography. Sickle cell hemoglobin S is transmitted through an autosomal recessive gene. It is mainly observed in black people. 1 in 400 black Americans are affected. Sickle cell trait affects 10% of black Americans. There is no gender predominance in this disease. Signs and symptoms. Physical examination varies depending on the degree of anemia, as well as the presence of acute vaso-occlusive syndromes or neurological, cardiovascular, genitourinary, and musculoskeletal complications. There is no clinical laboratory finding that is pathognomonic, that is, anticipating it, to the painful crises of sickle cell anemia. The diagnosis of a painful episode is based solely on medical treatment and physical examination. The bones are the most frequent site of pain. Dactylitis or hand-foot syndrome, that is, the painful and acute swelling of the hands and feet, are the first manifestation of sickle cell anemia in many infants, but as infants cannot say that their fingers hurt, these are shown with irritability and refusal to walk. After breastfeeding, musculoskeletal pain can be symmetrical, asymmetric or migratory, irradiated. It may or may not be associated with swelling, low fever, redness and hot. In both children and adults, sickle vaso-occlusive episodes are difficult to distinguish from osteomyelitis, septic arthritis, synovitis, rheumatoid fever, or gout. When there is abdominal or visceral pain, sequestration syndromes, spleen and liver, or the possibility of an acute disease, such as appendicitis, pancreatitis, cholecystitis, urinary infections, PID, pelvic inflammatory disease, or malignancies should be ruled out. Pneumonia appears during the clinical course of 20% of painful phenomena, asking to manifest itself, such as chest or abdominal pain. In adults, chest pain can be the result of costal vessel occlusion, usually preceding a pulmonary phenomenon. Lumbar pain also usually constitutes the symptomatology in adults. Acute chest syndrome manifests with chest pain, fever, wheezing, tachypnea, and cough. The thoracic X-ray reveals pulmonary infiltrates. A frequent cause is microorganisms, such as mycoplasmas, chlamydia and viruses, heart attack and fat embolism. The musculoskeletal and cutaneous anomalies observed in sickle cell anemia include leg ulcers simulating a cutaneous vascular complex, especially malleolar, and deformities at the level of the shoulder and pelvic girdle caused by a vascular necrosis of the femoral and humeral head. Endocrine alterations include delayed sexual maturity and late physical maturity, especially evident in children. Neurological abnormalities seen on examination may include seizures and altered mental status. Infections, especially salmonellas, mycoplasmas, and streptococcus, are relatively common. Severe splenomegaly secondary to sequestration is often seen in children before splenic atrophy occurs. Differential diagnosis. Thalassemia, iron deficiency anemia, leukemia, osteomyelitis system, osteomyelitis, septic arthritis, synovitis, rheumatoid fever, gout, vasculocutaneous syndrome, acute illnesses such as appendicitis, pancreatitis, cholecystitis, urinary tract infection, pelvic inflammatory disease, malignant neoplasms, thoracic organs, acute chest syndrome, lung infections, heart attacks, pulmonary embolisms, splenic diseases, liver diseases, neurological diseases, hemophilia. Medical assessment. Screening of all neonates regardless of breed is recommended. Screening can be done by the sodium metabolite reduction test. Hemoglobin electrophoresis also confirms the diagnosis and is useful for diagnosis and useful for identifying variants of fetal hemoglobin and hemoglobin A2. Lab tests. Anemia, caused by chronic hemolysis, reticulocytosis, leukocytosis, and thrombocytes are common. Bilirubin and LDH elevations are also common. The peripheral blood smear may reveal sickle cells, target cells, poikilocytosis, and hypochromia. There may be elevations of BUN and creatinine in patients with progressive renal failure. Urinalysis may reveal hematuria and proteinuria. Diagnosis by images. Chest X-ray is useful in thoracic patients. Cardiomegaly may be evidenced in chest X-ray. Bone court is useful to rule out osteomyelitis, generally secondary to salmonella. MRI is also effective in diagnosing osteomyelitis. Brain court or MRI is often necessary in patients with neurological complications such as TIA, stroke, seizures, or altered mental status. Transcranial Doppler is a useful technique to identify children with sickle cell anemia at risk of stroke. In the treatment there are three types of treatment: the non-pharmacological treatment, the acute treatment and the chronic treatment. Non-pharmacological treatment. Patients should be instructed to avoid situations that may precipitate the sickle cell crisis, such as hypoxia, infections, acidosis, and dehydration. Maintain adequate hydration. Correct hypoxia. Acute treatment. Aggressively diagnose and treat suspected conditions, salmonella, osteomyelitis, pneumococcal conditions, heart attacks and splenic atrophy. Combined treatment with the cephalosporin and erythromycin plus incentivized spirometry and bronchodilators are useful in patients with acute chest syndrome. Provide analgesia during vaso-occlusive crises. Medications must be given according to a strict schedule, in which the intervals between doses do not extend beyond the duration of the desired pharmacological effect. Mepridine is contraindicated in patients with renal dysfunction or CNS disease, since its metabolite, normpridine, excreted by the kidneys, causes seizures. Narcotics, like morphine, 0.1 mg, kg intravenous every 3-4 hours or 0.3 mg, kg orally every 4 hours, should be administered according to a strict schedule, not on demand, with rescue doses to sudden pain when needed. If there are contraindications, the concomitant use of NSAIDs should constitute the standard treatment. Should be instructed not to administer narcotics if the patient is heavily sedated or with respiratory depression. If the patient shows signs of improvement, narcotics should be gradually reduced. In order to prevent withdrawal syndrome, it is necessary to observe the patient taking oral analgesics for 12-14 hours before leaving the hospital. Analgesics should be administered in combination with the psychological, behavioral and physical treatment of this disease. Aggressively diagnose and treat any potential complications, like femoral head necrosis, priapism, bone infarcts, and acute chest syndrome. Avoid routine transfusions, but consider early transfusions in patients at high risk of complications. Indication of transfusions in these cases are aplastic crisis, severe hemolytic crisis especially during the 3rd month of gestation, acute chest syndrome, and high risk of stroke. Hydroxyurea, 500 to 700 mg, DES, raises hemoglobin F levels, and reduces the incidence of vaso-occlusive complications. In general they are well tolerated. The complications mainly consist of reversible neutropenia. Replace folic acid, 1 mg orally per day. Chronic treatment. Recommendations for the specific treatment of fever, infections, pain and specific complications should be reviewed. Genetic counseling is recommended in all cases. Avoid unnecessary transfusions. Exsanguine transfusions may be necessary in patients with acute neurological signs, with aplastic crisis or undergoing surgery. allogeneic stem cell transplantation can be curative in young patients with sickle cell anemia. However, the mortality rate with this technique is almost 10%. In addition, bone marrow recipients have a high probability of being infertile, and there is undefined risk of chemotherapy-induced malignancy. Penicillin V, 125 mg per should be administered twice a day at 2 months of age, increasing the dose to 250 mg twice a day at the age of 3 years. Penicillin prophylaxis can be interrupted at 5 years of age, except in the splenectomized child. Medical referral. Hospitalization is generally recommended for most crises and complications. Psychosocial counseling and support structures should be strengthened. Comments about the disease. Both patients and their families should receive genetic counseling and be aware of the difference between sickle cell disease and sickle cell disease. Regular immunizations and pneumococcal vaccination are recommended. The prophylactic administration of penicillin at birth, and a punctual administration of pneumococc and H. influenzae type B, have led to a significant decrease in the incidence of such infections. The pneumococcal conjugate vaccine, called heptavalent, should be administered as 2 months of age. The 23-valent unconjugated pneumococcal vaccine is given after 2 years of age, with a single booster dose being given 3 years later. The flu vaccine can be given starting at 6 months of age. Patients should be counseled about a balanced diet and folic acid supplements. The presence of dactylitis, HB7, or leukocytes in the absence of infection during the first 2 years of life, indicates a high risk of severe sickle cell anemia in the future. In patients with sickle cell anemia, chest syndrome is often precipitated by fat embolism and infections, especially community-acquired pneumonia. In elderly patients and those with neurological symptoms, the syndrome generally evolves into respiratory failure. Polexamer 98, a non-ionic surfactant with hemorrhagical and antithrombotic properties, has been shown to produce a significant, albeit relatively small, reduction in the duration of painful episodes and to increase the proportion of patients who achieve resolution of their symptoms. An additional effect. This was observed in patients receiving concomitant hydroxyurea. Pulmonary hypertension is a complication of chronic hemolysis and is associated with an increased risk of death. It can be detected by Doppler echocardiography in more than 30% of adult patients with sickle cell anemia. Cardiac catheterization will confirm the diagnosis. It is resistant to treatment with hydroxyurea. Thank you very much for watching the video. If you liked it, like the video and subscribe to the channel to grow together. Greetings.